The idea that the patient should get the same exact care they're going to get in their ICU bed when they're waiting 15, 18 hours in the ED for it to open up. So my name is Scott Weingart. I'm the Director of Emergency Critical Care at Mount Sinai and Elmhurst Hospitals in New York City. And pretty much everything I do is off-label. I'm taking money from no one, and I only speak for myself. So the lecture you've come to see today is called Just the Pearls. And I don't know if you know how it works with these ACEP lectures, but basically you get a letter in the mail and it tells you what your topics are. You don't choose. It's always a surprise each year. So I opened up the envelope and I had a subarachnoid talk. Great. And I had to talk about advanced ventilatory management. Right up my alley. And then I looked at this one, Just the Pearls. What's this? And they said it's the ultimate lecture for the ADHD emergency physician. Well, that seems a little bit weird, but okay, I'll keep reading. And then they told me they want to see 20 tips in 60 minutes. And I said, impossible. You can't do that. It's against every single didactic point out there. You don't try to teach 20 things in 60 minutes. You try to teach 3, 4 things in 60 minutes. But we're emergency medicine, and we do the impossible every single day. And that night, I was watching this movie. Anyone can identify this? It's one of the best zombie movies out there. This is 28 Days Later. And I said, forget 20. They want me to do 20. I'm going to do 28 tips in 60 minutes. 28 tips, 60 minutes, we'll see how we do. Now, I'm going to go quick. That's because it's for the ADHD emergency physician. So if there's anything that I went too quickly on, if you go here, I have updated syllabus, I have videos, I have audio, I have links to podcasts, I have everything that's going to fill in the gaps if we go too quick with these 28 tips. So mcrit.org/ACEP. Now, we're going to talk about this in the setting of where I work, which is a resuscitation and critical care area in my adult ED. So we call it the RAC. And this is 2 of those beds in there. That's one of our excellent ED critical care nurses, looking very happy, I might add. And it's empty when I get in there. 7 beds all empty until about 2 minutes into me drinking my coffee, the phone rings. And that's our notification line. And we're getting a 58-year-old male in cardiac arrest. He was in VFib, they shocked him 2 times, and now he's in asystole. He's intubated, and he's going to be here in about 30 seconds. So the first question I always ask myself when I'm getting these cardiac arrest notifications is that endotracheal tube in the right place? I've been burned. Now, it used to be when I was a resident, we would get in there with a laryngoscope and we'd try to see where it was going. It never really worked so well. That big piece of plastic always got in the way of my visualization. And it was always kind of a cluster. Until we got quantitative end-tidal CO2. And now, that's all we use to confirm these tubes. Pretty much as soon as they hit the door, we hook up the end-tidal CO2, and we know instantaneously whether that tube's in. Colorimetric CO2 will not work for this. It's not going to detect the incredibly low levels in a cardiac arrest patient. I would argue every ED in the country should have at least 1 quantitative end-tidal CO2 monitor. There was a use study out of the Great Britain Commonwealth where they discovered a lot of the patients that were dying were due to unrecognized esophageal intubations, but even worse, ones that were properly placed in the trachea that then dislodged. And so they are now recommending in every ED all across Great Britain quantitative end-tidal CO2 for the entire patient course time in the ED.